everyone, my name is Delroy, a third-year resident at Cedars-Sinai Medical Center in California. I'm here to present an interesting case for you all. This was an 83-year-old male with history of metastatic melanoma of a cervical lymph node with unknown primary site. The melanoma was diagnosed in 2016. And important to note that BRAF V600E and V600K were not detected. He underwent a year of immunotherapy with PD-1 inhibitor. About 5 years later, he developed a 1.3 centimeter liver mass. Here is a representative photo of the liver mass. We can see vaguely nodular architectures of epithelial cells with lymphocytes infiltrating. Going on high power, we see the cells are discohesive. They are epithelioid with graphenoid appearance, with pink cytoplasm, as well as chromatin and prominent nucleoli. Scattered mitotic figures and nuclear inclusion are noted. We consider many differential, including metastatic undifferentiated, dedifferentiated melanoma, XCC, metastatic carcinoma, sarcoma, and lymphoma. Immunostain were performed, and here you can see melanocytic markers, including melan A, S100, SOC10, and HMB45 were all negative. 5-HMC was retained, and BRAF V600E were also negative. The summary. Other less specific melanocytic marker like MITF and tyrosinase were also negative. Keratin, XCC, GIST, rhabdomyosarcoma, liposarcoma markers, as well as lymphoid markers were all negative. The immunophenotype was compatible with an undifferentiated neoplasm that has lost all of the lineage markers. Therefore, now the differential included undifferentiated, dedifferentiated melanoma, sarcomatoid XCC, sarcomatoid metastatic carcinoma, and undifferentiated polymorphic sarcoma, or UPS. NGS were performed, and the tumor was found to have BRAF V600R, TERT, IDH1, and MDM4 mutations. Given the history of melanoma, the tumor lost all of the lineage markers and BRAF V600R mutation. So the diagnosis of undifferentiated, dedifferentiated melanoma was favored. And I'm going to talk a little bit about the differentiated, dedifferentiated melanoma. Undifferentiated, dedifferentiated melanoma can occur as a primary or metastatic melanoma, and metastasis is more commonly seen. So undifferentiated melanoma lacks histologic and immunophenotypic features of melanoma altogether. In contrast, dedifferentiated melanoma is a biphasic tumor composed of conventional melanoma component with a retained expression of melanocytic markers and undifferentiated components. Here are some photos of conventional or differentiated melanoma. We usually see nests of epithelial cells. The nests are variable in size and shape. We also can see pigmentation, and we usually see nuclear inclusion and red nucleoli. Typical morphology of differentiated melanoma is a biphasic pattern of conventional melanoma transitioning into malignant spindle cells, as you can see here. Dedifferentiation can be observed in any conventional melanoma subtype. Most undifferentiated, dedifferentiated melanoma show pleomorphic multinucleated and binucleated tumor cells mimicking UBS or undifferentiated pleomorphic sarcoma. The second most common appearance is rhabdoid differentiation, which varies from focal to extensive, mimicking pleomorphic rhabdomyosarcoma. Keep in mind that loss of INA1 is a helpful feature to distinguish rhabdomyosarcoma from your undifferentiated, dedifferentiated melanoma. Other morphology can be seen in undifferentiated, dedifferentiated melanoma is NPNST-like pattern. Undifferentiated, dedifferentiated melanoma can mimic myxoid liposarcoma, pleomorphic myxoid sarcoma, chondroblastoma, giant cell tumor soft tissue, small round blue cell tumor forming glands, or primitive small round cell tumor with neutrophil like matrix. So moving on to immunophenotype of undifferentiated, dedifferentiated melanoma. Similar to some melanomas, such as single cell and desmoplastic melanoma, undifferentiated, dedifferentiated melanoma can lose the expression of one or more melanocytic markers. Undifferentiated, dedifferentiated can apparently express keratin and myeloid markers, which are useful clues for diagnosis. This entity also randomly express neuroendocrine markers and other non-specific markers like CD10 and vimentin. Here is the largest case series of undifferentiated, dedifferentiated melanoma, collected 35 new cases and 15 previously reported cases. Important to note that the majority of cases were misdiagnosed. Only 11 cases were actually diagnosed with melanoma. Driver mutations were found in undifferentiated, dedifferentiated melanoma cases, including BRAF and RAS, MX1, and KIS. There are other studies also reporting similar findings in undifferentiated, dedifferentiated melanoma. And so we all know that BRAF were not found in UPS, NENST, and other sarcomas. For these reasons, BRAF can be used as a surrogate marker for undifferentiated, dedifferentiated melanoma, particularly if the genotype of the primary tumor is unknown. Undifferentiated, dedifferentiated melanoma is usually seen in elderly patients, more commonly in males than females. Undifferentiated, dedifferentiated can occur as a primary or metastatic melanoma, and patients may have history of melanoma immunotherapy, and this entity is not associated with irradiation and can occur at any anatomic site. And important to note that multifocal disease typical of melanoma spread than carcinoma or sarcoma. Here is more case series of 7 patients with undifferentiated, dedifferentiated melanoma were followed up for about 25 months in average. 2 patients died from their disease and 3 developed metastases. No local recurrence were reported. Prognosis of undifferentiated, dedifferentiated melanoma doesn't seem to be more aggressive than other melanoma subtypes. However, we need more studies to establish the prognosis of this entity. In conclusion, undifferentiated, dedifferentiated melanoma is a unique clinical pathologic entity that lacks the characteristic morphology and immunophenotype of any conventional lineage. This entity can transdifferentiate and show features of almost any entity, such as epithelial or rhabdomyoplastic tumors. Important differential diagnoses are undifferentiated pleomorphic sarcoma and sarcomatoid carcinoma. Although undifferentiated melanoma and UPS or undifferentiated pleomorphic sarcoma can have a similar pleomorphic appearance, prominent rhabdoid and epithelial cell features, as well as striking cytologic variants more compatible with melanoma. UPS doesn't really have a specific molecular or cytogenetic abnormality. However, undifferentiated to differentiated melanoma usually harbor recurrent genetic alterations, so molecular studies are very useful to help distinguish the two entities. And we all know that occasionally sarcomatoid carcinoma is composed of sarcomatoid component only and can lose all of the lineage markers, including cytokeratin. Therefore, differentiation of sarcomatoid carcinoma from undifferentiated to differentiated melanoma requires really careful review of clinical information, histology, immunochemistry, and molecular diagnosis. And keep in mind that it's very critical to distinguish undifferentiated to differentiated melanoma from UPS and sarcomatoid carcinoma because the management and treatment are completely different. Here are my references. Thank you for your attention.